and he will be speaking about orthopedics and also Thank you.
Thank you very much for that kind introduction. First and foremost, thank you guys for coming and showing up. We are very proud as an organization to be partnering with Powers Health. As you'll see, for anybody that stays through this entire presentation from beginning to end, they've really made a huge effort. Paula in the back is here, and she was very integral to this, as are many people within the administration, of really bringing the best, brightest orthopedic surgeons, not locally, but really, truly globally. Like in the world, these are some of the strongest orthopedic surgeons you will ever meet. They've trained at the best places. They've really mastered their craft. And you'll see that come out in the talk. The degree, the type of technology that's being done here, the national and international recognition that my colleagues and my partners have been able to accomplish is truly incredible. Having partnered with Powers, the dominant healthcare system in this region, really pulls a lot of expertise together so that we're able to come out and provide the best possible care for people from around the country and around the world who come in here. So, without anything further, we'll jump right in here. This has been an area of massive interest to me. So I'm now 22 years out in practice. I came in 2003. And when I first started, and we'll get into this in the talk in a little bit more detail, nobody has like a positive thought about like spine surgery. I've done it for 22 years. I've never had one patient come into my office and say, I am so excited to see you. I've always wanted to have spine surgery. That's like a never event. And there's so many times, because I also really, really like plastic surgery when I was at WashU in St. Louis. I was like, imagine people coming in and saying, I'm going to get my nose job finally, or my butt lift, and you can wear the rings and the jewelry, and I have a Ferrari. It's not like that for spine surgery. People are literally coming in, they're falling in. These are doctors and nurses and their families and people that you've known for years, and they come into your office and they look like someone's literally taking their soul out. They look like they're homeless, they're exhausted, they're not sleeping. It's truly, truly debilitating. When we talk about options for these people, clearly they're on their hands and knees and they're begging for help. Patients literally will tell me, it hurts so much to cut my arm off, cut my leg off. That's how bad it can feel. And maybe some people in this room have been through that, but it is really terrible, terrible. Our only options historically were these really wide open surgeries, screws and rods everywhere, and the outcomes were somewhat uneven, and the recoveries were certainly very, very long. My goal when I first started this, so I did engineering before I went to medical school, was that there's got to be a better way. Got to be able to do it smaller. We have to be able to preserve motion, and so on and so forth. And so this topic to me is, on some levels, sort of part of the culmination of my career and where I wanted this space to go. We're now able to, again, take people in, instead of fusing every disc, replace this, maintain motion, and we're able to do these procedures inside of an hour, and we're able to not only do it inside of an hour, we're able to do it outpatient. Some of the papers that we'll present are papers that I wrote on my patients. And these are some of the very, very early papers that were out there that were proving sort of proof of concept here. So again, a little bit about me. I did my spine fellowship at Rush in 2003. And again, I feel like I was trained with sort of the grandfathers of spine surgery. A lot of those guys have now retired, but the fundamental and the foundation principles of what they taught me will always stay with me. I've been in Northwest Indiana since 2003. I've been in the same office with the same group my entire career, which is also sort of a never event. But we see a lot of people that move around. They took a job and then they left. They took a job and then they left. I've been very fortunate to take care of patients in Northwest Indiana on and on and on again. Patients have told me one is they're like, what are you doing here? That's the one thing. And the other is we're so grateful to have you here. And as a surgeon, I can tell you, there's no better feeling than being able to help people and having that gratitude come back to you. I was asked to be an associate editor for Spine, which is basically the primary spine journal, and I still sit as the associate editor and a reviewer for IJSS and also JOCN. I had the opportunity to be a design surgeon for a minimally invasive lower back fusion, and I did that 15 years ago. I had the opportunity to teach surgeons from around the world. We had surgeons from Japan, England, Australia, all come to Northwest Indiana to learn these types of techniques. So it's been a very gratifying professional career for me. I've published at every possible meeting. So Rick, ACS, Khanna, Spine, SISRS, ISAS, SNIS. SRS. The one that's not on the list because I didn't update this in time is LSRS, which I did 2 years ago now. That was the one meeting I kept submitting papers for podium presentations and they kept rejecting it. 2 years ago I got it. That was the last one on my list. And again, my focus of my practice has always been on, number one, motion preservation and outpatient surgery, and then minimally invasive surgery. So literally people are getting up and walking out of that procedure that day feeling better. When I started, that was a never event, and for me, I want that to be a universal event. So this is a paper, and some of my colleagues on this are, again, some of the people that are internationally known for moving this ball forward. And I felt very fortunate to be included in that group, and it was like breaking through the glass ceiling of minimally invasive surgery. What can we do, and how can we do this? So again, in concept, everybody thinks it's a terribly long procedure, very high complication rate. Don't let anybody ever operate your spine. I probably hear that 5 times per clinic per week, 22 years. Right? My aunt told me never let anybody operate on me, my such and such. All I can ask those patients or tell those patients is ask about me, read about me, Google me. You're going to get a very different experience. The key was to advance this technology, improve the outcomes, and shorten recovery periods. And again, this is really the leaders in minimally invasive surgery. So the number one question I always get asked by patients and providers fall into 3 categories. Number 1 is the surgeon, number 2 is the facility, and number 3 is the complexity of the case. All of these different categories lead to or hurt you from reaching good outcomes. Okay. First and foremost, I think the surgeon really matters. When people talk about a lumbar fusion, is not the same as a lumbar fusion. Is not the same as a lumbar fusion. How you do it, how you manage soft tissue, your incision size, how quickly you get through the surgery, what is your complication rate? And we'll get into that later in the talk. I actually post my complication rate. That's something that most spine surgeons never do. And I see a lot of patients with second opinions, and they're like, there's a 50-50 kids, you're going to get better. All people have complications. This happens and that happens. But I actually went and I reviewed it. We went back 8 years and reviewed almost 2,000 of my spine surgeries in the last 8 years and put my complication rate on my website. The facility that it's being done in. Is it a tier 1 facility? Do they have the technology? Is it an outpatient facility where they know exactly what they're doing? And as we move from inpatient to outpatient, for certain select patients, understand it has to be a place that has a lot of deep experience doing it. Because in order to do something very, very well, you have to do a lot of it, and you have to have a team and surgeons committed to doing it at a very, very high level. And then the complexity of the case. There's some cases that, quite frankly, I tell patients, I wouldn't go forward and have that surgery. I think it's too much surgery. I think the risks are too high. I think that people could suggest and recommend screws all the way up to down your spine, and those are my mentors. Those are the guys that train me. I'm just not sure that it's worth the recovery. I'm not sure that it's worth the risk that you're taking on in order to get one. If you're functioning, even not at what you consider to be your highest level, don't just jump into a big case hoping and praying for the best at the back end, because it's not necessarily a certainty. So that's a huge part of decision making. So this is, she was my first cervical disc replacement. And now again, this surgery was done, I was probably say 12, 10, maybe 10 years ago. So she's actually a nurse at Methodist Hospital. So I've never, ever in my 22 years stepped foot inside Methodist Hospital. But she asked around, and let me be very clear here because for some people in the medical profession, I can see Ann over here trying to sneak in, didn't say hi. But there's nurses and nurses talk. And nurses talk a lot. And nurses know. And nurses will tell you, that's the right guy, that's not the right guy. And she had asked around, and she came in and she said, I want a cervical disc replacement, and I want you to do it. And I was like, listen, this is a brand new technology. We don't have a lot of deep experience with this. And she said, I know that, but everybody that I've told, that I've talked to said, you are the guy to do this. And we operated on her, and I can't even believe how well she did. And so this is a picture of her x-ray over here. I'm scared to press this red button, but I think it's a laser. The laser's not going to hit the screen. So these are the disc replacements here. So the few things to understand are, number one, zero profile. So there's no plate in the front. There's no screws that go up and down. So this is a totally unconstrained device. So you have a metal plate, a polyethylene core, and then another metal plate. And it's basically wedged into place. She maintained all of her motion. In fact, she regained motion that she had previously lost, which is really incredible, when you think about it from a spine standpoint. This was our holy grail, what we were all trying to get. So now, and it says 200 levels, which this is a dated slide. I've now done close to 500 levels of disc replacement. And I have patients coming from, I've got a patient flying from Alaska just for a disc replacement, with our group. I presented the paper in 2019 on patients returning to work after work comp injuries, and we were doing disc replacement. And these patients were able to return back to work. Work comp patients tend to be the most challenging patients to deal with because there's some incentive sometimes for them not to return and to stay off longer. Those patients return back to work within 40 days, which was extraordinary. That's usually a 3 or 4 month return to work, and we cut it down to 40 days. This is a technology called the OR. We have this at Powers Health in Munster now, and the case I did this morning, we utilize this. We're able to take intraoperative CT scan, basically well-targeted screws directly in the bone, very, very small incision. So this gentleman was a larger gentleman, and he had one incision on the left, one incision on the right, and had a lumbar fusion done. He'll get up, he'll probably go home later today. When I first started, standing was a 4-day length of stay for that procedure. And we had gotten it down to 2.5, and now this guy's going to go home probably within a few hours, which is, again, really remarkable. So these are the questions. You got to ask these questions. I'm stunned that when I see second opinions and I talk to patients about this, they don't ask these questions. So this, I think, is a huge slide. Number one, ask about that doctor's data. If they can't give you hard numbers, probably is not the best doctor to see. If they're not written about any of their own or published in peer-reviewed, either papers or peer-reviewed international spine meetings, probably not the best person to go with. Make sure they're fellowship trained. I think in order to be from a spine surgery standpoint, you've got to be doing over 250 spines. We see, unfortunately, guys, 100 spines, 80 spines. It's very, very hard to be very good when you're not doing significant numbers. What's your complication? And if they say, well, I don't know, that's not a legitimate answer. Not in 2025, right? You would never, the thing I always tell patients, you would never buy a car and not know, an electric car and not know how much, mileage it would be. That you drove around the block, it's just like, all the charge ran out. Well, why? Well, the dealer told me it drives for a while. You would never accept that, so why would you accept that from a spine surgeon? You should be able to set expectations, be honest with you about what to expect, what the length of stay is going to be, how long it'll take to recover, how long you need to be on pain medication, what limitations you will or won't have after the procedure. You got to make sure that the surgery is well performed. And that's a little bit difficult for patients. You don't really know what you're looking at. But that's where word of mouth really helps. When you ask people, when you talk to people, when you do your research, these things tend to come to the and then as a surgeon, do you send a lot of your patients to pain management after surgery? Are you sending patients to a lot of spinal cord stimulators? These are not never events, but they should be much the exception and not the rule. Does it happen occasionally? It should happen occasionally, but it should not be every single patient got 3 epidural injections, got 3 facet blocks, got a discogram, got a fusion, went back to pain management for more injections, and then got a spinal cord stimulator, and has now got a stimulator on opioid medication. What did we do? What did we do here? It all comes down to the primary thing that surgery was probably not indicated. And even if it was indicated, it probably wasn't performed very well. Complications are expensive. The debilitating for patients are debilitating for their families. Infections, failed surgeries that all lead delays birth or care and increased costs. So this was the data I was talking about. So the 8-year data, when we data mined my cases, was 1,898 spine surgical cases. Overall, revision rate was 1.2%. And again, it's fascinating to me that we don't have that, transparency when patients are trying to choose. I think a surgeon, especially a spine surgeon, should be able to give you these types of numbers. And if they just say, I don't know, I never measured it, that tells you something about the focus that surgeon has on you and your care. Last year, I did 287 spine surgical cases. Just to give you an idea, the infection rate is 0.54%, which again, I think is like nationally low or the lowest. It goes back to technique, being very thoughtful about who you operate on and how you do it, small incisions, being very efficient when you're in surgery, getting that patient up and getting them out. If they can't provide you with the data, go find another surgeon. Number 2, you never buy the car unless you basic things about the car. Number 3, again, we talked about the fact that if you're not collecting data, it's not really acceptable. Complications happen, and I don't know my rate, not really acceptable. Get it right the first time, ask surgeons about the infections and return surgery within 30 days. Even if you had surgery with someone else, you can still be a great candidate for minimally invasive surgery. So there's a lot of revision surgery that I do. Unfortunately, some of them were patients I said, you know what, I wouldn't suggest or recommend surgery. They went and had surgery, and then they came back and the doctor still listened to you, I'm so much worse, and you fix it now. Even in those situations, you can go back and fix those cases. Where they've had surgery with somebody else. It was my senior partner, who's retired now, Joe Hag. He had a very close friend of his who was an MD PhD at IU in India. The guy had 5 surgeries. And Joe said, can you please look at him? He's a very close friend. He was a very active guy, ran marathons and all this stuff. He barely went along. And he came in, and the surgeries that had been performed just hadn't been performed. And we went in and again used a minimally invasive approach, and he got his life. It was really, really extraordinary. And it was again a small incision. Just again going back to those fundamentals of my mentors, and checking all of those boxes and getting this guy back up on his feet. When there's an option to go big or go small, and again, this is what I talked about when I started, I always go small. Always, always, always. There's paper, and I don't think, I did go big. In 2017, I went back, and when patients came in and they asked for a second opinion, a lot of times they'll say, I'd like to try just decompressing this and try to avoid the instrumentation and the fusion. And you go back and forth. And in my mind, I always felt that the success rate of that would be 85%, of those patients were able to avoid fusion, 75, something like that. That was my sense. When we actually went back and did a deep dive in the numbers, it was over 90% of those patients. 92% of those patients, to be precise, did not require conversion to a fusion at 3 or 4. So that's a hard number now I can give patients. Now, part of it is my own brain's algorithm in determining, you know what, I think we actually need to do a fusion on this for this and that reason. But if I felt that it was reliable to try to do decompression, 92% of those patients did not require fusion. Also, not at all a fan of multilevel fusion or cervical fusion. I think in my 22 years, you can count on one hand the number of times I've had to do that. in the last year on year, less than 5, probably less than 3. Tumor, trauma, infection, a big revision because something else went wrong. But it should never be done for back pain. It should never be done for just current value degenerative disease. Patients just do not do well with that type of surgery, and that just takes counseling. So here's an example to get back to disc replacement a little more detail. 50-year-old, he had 3 months of neck pain, arm pain, and weakness after a twisting injury. He went everywhere. This guy went to every single place, all throughout Chicago. And again, he heard about me, and I think I may have taken care of one of his family members. And they said, we just want you to do the surgery. So what you see here is a relatively speaking, and I'll say relatively, and I'll explain why, well-preserved spine. But the guy does have some arthritis here. He has significant collapse of the disc space at this level. So if you compare this to this level and this level is definitely squashed down. And it's been squashed down here for a little bit because you can see some of the spurring in the front with that. Early on in your disc replacement journey, there's a very tight window for doing disc replacement. And now that I'm at the 500 level mark, I've expanded that. So I take on more complicated cases. So there would be a significant number of less experienced disc replacement surgeons that would say, you should have a fusion because you have some arthritis and I don't want you to have any pain anymore, so we'll just do a fusion. There's a few of us nationally, there's probably less than 10 or so, that all day long this is a disc replacement. So what you see here, this is an MRI, kind of fuzzy, but you kind of see the clean line through here, and then that's the disc that's spitting out, and that's the spinal cord coming back. So we took this patient to surgery, and then we performed the disc replacement, and what you see here is we're actually able to trim off that arthritis and restore that motion intuitively. Even if you know nothing about orthopedics or spine surgery, this just looks like a much better option than a plate and cage and screws, in the neck. And you maintain motion. So the next challenge for us as orthopedic surgeons are biologic advances, right? We're able to take your DNA and in the lab build a biologic disc. This could just be considered a spare tire and just waiting for you to put your own disc back in there, right? We haven't burned any bridges. We haven't done anything that we can't undo. Right? So I think that's really, really, an extraordinary option for this patient. Patient selection is huge. The one thing that I learned early in my career, my mentors taught me this, but until you've had a lot of experience taking care of patients, you can't really understand this when someone else tells you this is the right or wrong thing. I have teenage kids now, so I'm trying to tell them things, and all I hear are my parents trying to tell me the same things at that age. So yeah, we could go on for hours about that. But my mentor, who's now retired, Howard On, he used to say patient selection is key. And it's like, yeah, that patient's in pain, and I'm selecting them because I'm going to make them better. It's not like that. If that patient is not motivated to improve, does not have that family, that infrastructure around them, and that positive attitude, it may not, even the most perfectly done surgery may not help that patient. And so that's where you become very, very selective about choosing people that you also believe have a good chance of getting better. The number I use now in my own mind is if I'm not 95% certain I can help you, I'll tell you don't have the surgery. Go try this and go try that. Focus on one level and ensure the other segments are in excellent condition. When you take a patient that's got just absolutely, arthritis ridden all the way up and down their spine, those patients, you can't dismiss the fact that they're in pain, but screws and rods are not the solution. That will not make the patient better. It will make that patient different, and in many cases, make that patient worse. And so just remember that. And again, the multi-level surgery should be avoided. So this is what the device looks like. This is called the Mobi-C. At the time, I had the largest experience with this device. And again, it's a metal roof, a free floating core. So this is considered an unconstrained device, and then a base. I presented this paper looking at doing these procedures outpatient. Now, in 2025 and 2019, this was kind of like brand new. And so this got accepted at the North American Spine Society and then the International Society for the Advancement of Spine Surgery. And we looked at 19 consecutive patients. All patients were sent home approximately 2 hours after surgery. So just think about what we talked about at the beginning. And now we're sending people home in 2 hours. There were no 30-day readmissions, 0 infections, and the blood loss was less than 50 cc. I was the only surgeon out there. So when you see this big data where they data mine and they look at across the country and this and that stuff is helpful, but to me this is more telling. I really want to know, how did my patients do? The patient that I selected, that I operated on with my technique, what does that look like? Again, there's nothing but advancements here. So again, you see the same collapse disc here, and again, a lot of surgeons don't like the fact that there's arthritis over here. This is called the simplified disc. So I've now converted, and this is my primary disc replacement. This is a polyethylene roof and a polyethylene floor with a ceramic floor. So this is the only MRI compatible disc replacement on the market. So that other disc replacement had metal. So when you would do an MRI, you completely black out everything. And we get calls from radiologists like, oh my God. And I'm like, was that a MobiC patient? And they were like, yeah. And I'm like, okay, just take a breath. It's not nearly as bad as you think it is. It's just artifact that MRI, the magnet sprays off that metal and it just looks like black everywhere. You can MRI all the way through this. And you can see over here. Now we thought the other image looked good and it was intuitive. I think this one looks like a Ferrari because you can barely see the top and the bottom. You just see this floating core. We were able to take down the osteophytes. You know, you talk about turning back the hands of time. It's almost like, you know, you got I call this like the brand new baby disc. And it's really elegant. The other thing that's nice about this, which is a technical thing, is it has these keels. I always thought these were a little bit cumbersome until I had a lot of experience with this. These keels allow these end plates to really wedge inside these bones. So the keels are cut this way, and then it wedges into the bone, and it keeps that end plate stability. So with that MobiC device, there's no keel cut. So this takes a little bit more precision to do well, but technically this is a better device that will more likely than not have much better durability than that MobiC. I think I'm the only one in Northwest Indiana doing the Simplify. I feel very proud of a lot of the things that I've done here. When I first came out of training, there were a lot of academic institutions that I was considering joining, and Northwest Indiana has really embraced me. It's been an extraordinary run for us. Our group, Orthopedic Specialists in Northwest Indiana, ASNI, we have been voted best of the region for the last 14 years, and it's coming up again on the results for what's going to happen this year. I have a sneaky suspicion we may win again, but you guys will have to read the paper and check and see how that plays out. But we've really truly assembled the best and the brightest, and I'm very proud of my partners and what we've been able to do. Thank you. There were some questions about how the disc replacement works and where does it go. So you have to think about the spine is a bone, then a disc, and then another bone. The nerves run behind that. So when the disc gets injured, instead of staying between the bones, it spits out and it pushes on the nerves or the spinal cord. But when we do the surgeries, we take out the disc and we replace that space, that void that we've created, with either a fusion device, cage, screws and whatnot, or in this case, we've seen these disc replacements. There's no wrapping around the spinal cord.
You have a question here?
Yeah, it's a great question. That's a biologic fix. not a surgery.
So you're saying no, please, not from a surgical.
Yeah, three questions. One, you take Medicare and Medicaid.
My back office will probably not think so, but yes. Okay. Short answer, yes.
Two, I have, collapsed discs, osteophytes, and stuff like that. And the doctor wants to do a laminectomy and fusion of C2 to T1. What do I do? I don't want to.
I give a second opinion.
Can I get it with you?
And if you guys, on your notes paper, there's a QR code as well, and so all of your information in order to contact these doctors are there for you, and you can always go to Power Self and they can give you any of that information as well to make an appointment. Is there any other questions?
I have a comment. I just want to comment that where were you in my life? This is my neck from 2017, from C2 to T1, nothing but metal. And if this option was available at that time, I'm sure my neck would not look like this. My daughter has recently been diagnosed with some of those same concerns. You will see us in your office. Thank you.
I think we have time for just one more. There's somebody up here for a question.
Yeah, it's hard to say without a clinical picture. The MRI is an exam and trying to understand, what's bothering you. The one thing that, we didn't really talk about is it just depends. This is all I do. That's where I live, so I don't consider it dangerous, but this is the only thing that I do. You know what I consider dangerous? Loading the dishwasher in my house. To me, that's more dangerous. Again, it's hard to say. The one thing I will tell you that is very, very important for everybody to really kind of listen and understand is, I always tell patients, I take care of people, not images. So if images look bad and the patient is functioning at a high level, my tendency is to watch the waiting. So just remember that. Don't operate on images. It's something that we see a lot of younger spine surgeons do. I just don't think that's good medicine.
You said the center of what's in between the places ceramic.
Yeah.
Is it attached or is
No,
floating?
it's floating. Yeah. So that takes a lot of strain off of the end place and makes everything stay solid.
I forgot to mention, I have myasthenia gravis. Would that complicate what you're?
Yeah, that thing makes things, more difficult.
So,
That's an anesthesia related concern, yeah.
Why is neck pain? Are you an anesthesia? You want to see it? Fair enough.
All right, we have a 15-minute interval between, and so you guys can use the restroom, and of course, if you're staying for other ones, just make sure that